question?
Yes.
When I read this one, it's like that we try to find all the benefits of the intervention. But also read some papers show that after the patient got progression with the intervention, when they treat with the intervention again, the progression-free survival will be shorter, much shorter than that previous. So I just wonder, maybe these patients, they may have no other choice. There is no better drugs for them. They may choose some worse drugs or use the same drugs, but they get less benefit. So, I mean that their overall survival should be shorter than what we expect.
Yes, I mean, I think that speaks to this common treatment effect. The assumption that patients who switch get as much benefit as they would have got if they'd received it to start with is strong assumption, maybe quite unrealistic. I know a lot of clinicians, at least in the cancer area, almost as a rule of thumb, assume that as you move through different lines of treatment, the amount of benefit you get halves. Now, that's not always true because some drugs have very different mechanisms of action. And so if they have a very different mechanism of action, it's more plausible that you could still get the full benefit. But if we're thinking of drugs that have a similar mechanism, it becomes highly implausible that you'll get the same benefit. The benefit's going to reduce over time, yeah. But whether it's the same or reducing or how much it's reducing, that's the issue. We're trying to get as true an estimate of the benefit of a therapy as we can. And we don't want to underestimate the benefit, but we don't want to overestimate. So it's really quite a challenge. And it's an area where we're still learning. In a sense, we're at a fairly early stage just now. And, as if that's not tough enough, regulators are approving therapies earlier in development. So, for example, certainly the European Medicines Agency and the FDA, Food and Drug Administration in the US, are beginning to fast-track particular drugs and approve them on the basis of less evidence. Sometimes just stage 2 evidence rather than stage 3 trial. I don't know if this, I'm not sure the same's happening in Japan yet, but if it's not happening, it will be happening. It will happen. Regulators, they want to, naturally, they want to get new drugs approved. And there's quite a push going on for that. Now that implies we're going to have poorer data in the future than we even have just now. And so it's going to get tougher to make accurate estimates of how effective the drug is. So that's a real problem. Okay, let me just get to the summary. I keep banging on about this point, but it's really important. Economic evaluation requires a prediction about the future, because we don't really care what happens just during the trial. We need to know what happens during a trial, but what happens next. If we're to get accurate estimate of the costs and benefits, we have to look into the future. So that's all right. But the first problem is different methods will give rise to different answers. Different assumptions about which statistical distribution to use, or different ways of adjusting for treatment switching. They'll lead to different answers. Now, over time, and I've noticed it, well, I suppose I've been doing this for years, but even in the last 10 years, there's been quite a marked increase in the sophistication of the methods being used, which is good. It's good in the intellectual sense, it's interesting, it's challenging, but in the practical sense, it's good if our methods are getting better. But, as I've just alluded to, maybe the data is beginning to get poorer. Now that's a real worry. Now, there's a lot of publicity given to things like real-world data, and the idea that data increasingly might come not so much from trials, but maybe at least supplemented with observation of real patients just out there being treated. Observational data. That's quite encouraging in a way, that we should collect better data on real patients, because the patients in trials, I haven't said it, but as we all know, the patients in trials are highly selected, and they have very few comorbidities. They tend to be younger than the patients in real routine clinical practice. And so it's good that we're embracing real-world data. But of course, then you're embracing real-world confounders. At least in the trial, you've got very good data on people, what previous treatments they've had, etc. In the real world, you typically have much poorer quality data. So it's an interesting time, but a challenging one. Okay, so what I'm going to talk about tomorrow morning, Thursday's the day off this week. Tomorrow morning, I'm going to move this forward. I'm now assuming we've been able to model the time patients spend in different health states. We've solved all those problems. What we now need, if we're going to get the QALY, is the QA bit, the quality adjustment. And I want to introduce you to some of the issues and some of the progress we've made in doing that quality adjustment, in measuring patients' health states and giving a score to their health state. And then in the afternoon, I'll look at alternatives, such as money. Why on earth are we wasting time with all these QALYs? Why don't we get straight down to it and use money to value health? And there are some good reasons, but we'll look at them. Okay? So we resume tomorrow, same place, same time. And I hope, 3 hours of me is quite a lot to put up with. So I hope you get a good rest tonight, okay?